This class is on precancerous lesions and common specific tumors. Coming to the benign tumors, tumors are classified into benign and malignant depending upon their nature. The benign tumor is a tumor when its gross and microscopic appearances remain localized, which will not spread into the other sites and be removed surgically, while malignant tumors are the tumors that invade and destroy the adjacent structures, which spread to the distant sites through metastasis and cause death. Mixed tumors are the tumors that are derived from the multiple tissues which may have both the natures. Tumors are upon their origin into epithelial tumors and non-epithelial tumors. These are the few examples of epithelial tumors. Epithelial tumors arising from the squamous epithelium. The benign entity is called as squamous papilloma and malignant is called as a squamous cell carcinoma. Transitional cell epithelioma is benign and malignant, while benign is transitional cell papilloma and malignant is transitional cell carcinoma. Tumor arising from the glandular epithelium, benign is adenoma and malignant is adenocarcinoma. Likewise, hepatocytes, liver cell adenoma and hepatocellular carcinoma is the malignant, and tumor arising from the placenta, hydatidiform mole is a benign and choriocarcinoma. In the non-epithelial tumors, most common tumor is the tumor arising from the adipose tissue. Lipoma is called as the benign tumor and liposarcoma is the malignant entity. And tumor arising from the fibrous tissue, the benign is called as fibroma, malignant is called as the fibrosarcoma. Likewise, cartilage, chondroma and chondrosarcoma from the bone, osteoma, osteosarcoma. From the blood vessels, hemangioma and angiosarcoma. And nerve sheath, nerve cells, lymphoid tissue, nerve system. From the salivary glands, the most common benign tumor is the pleomorphic adenoma, and malignant is the malignant mixed salivary tumor. Here we are discussing about few precancerous lesions and the common specific tumors. What is precancerous lesion? Precancerous lesion is also called as a premalignant lesion, in which the lesions involving the abnormal cells which are associated with an increased risk of developing into cancer. The causes may be the risk factors that predispose to individuals to a specific cancer, like papilloma virus, which is a risk factor for cervical and anal cancers, as well as the cervical and anal dysplasia. Sun exposure in case of actinic keratosis and some skin cancer. These are a few examples for the precancerous lesions. Precancerous lesions occurring in skin are actinic keratosis, xeroderma pigmentosa, Bowen spaces, keratosis congenita. And precancerous lesions occurring in head and neck are oral submucous fibrosis, erythroplakia, mucophagia, lichen planus. Gastrointestinal precancerous lesions involve Barrett's esophagus, atrophic gastritis, colon polyp, Plummer-Vinson syndrome, hereditary non-polyposis, colorectal. The precancerous lesions in breast is a ductal carcinoma in situ. Gynecological precancerous lesions include cervical dysplasia, vaginal intraepithelial neoplasm, anal dysplasia, lichen sclerosus, Bowen stasis, erythroplasia of Quart. Precancerous lesions of urological system include bladder carcinoma in situ, while hematological precancerous lesions are monoclonal gammopathy of unknown significance. These are few common precancerous lesions. About few things. Actinic keratosis. Solar rays induced. These are the solar rays induced lesions occurring in sun-exposed areas, most commonly in a fair-skinned people. They are caused due to ionizing radiations. These lesions are tan brown, erythematous with a rough sandpaper-like surface seen over the dorsum of the hand. Microscopy of this shows hyperkeratosis, acanthosis, dyskeratosis, dysplasia, and some inflammatory cells in the upper dermis. This is the image showing hyperkeratotic lesions, actinic keratotic lesions over the dorsum of the hand and over the lip. The second is xeroderma pigmentosa. This is another precancerous lesion of the skin. This is an autosomal recessive disorder occurring in sun-exposed areas. The sunlight causes DNA damage. Microscopically, hyperkeratosis is seen in the skin. Melanin is present in the basal layers of the skin. The next precancerous lesion of skin is Bowen's disease. They occur as a solitary lesions. They occur in sun-exposed as well as non-exposed areas. These lesions are circumscribed, rounded, reddish-brown patches seen over the trunk, buttocks, and extremities. Histologically, they show hyperkeratosis, parakeratosis, and scattered dyskeratotic cells. Coming to the precancerous lesions of the head and neck, erythroplakia is the most common thing, much less common than oral leukoplakia. Erythroplakia is a red, velvety, eroded area within the oral cavity, which remains in level or may be slightly depressed in relation with the surrounding oral mucosa. Microscopically, the epithelium shows a marked atypia and has higher risk of malignant. Clinical oral leukoplakia is clinically defined as a white patch or a plaque on the oral mucosa which is more than 5 mm in diameter and which cannot be rubbed off. Pathologically, leukoplakia is defined as epithelial thickening, and leukoplakia is defined by WHO World Health Organization as a white patch or a plaque which cannot be scraped off and cannot be characterized clinically or pathologically as any other disease. Both leukoplakia and erythroplakia occur more commonly in males. The lesions may be of variable size and appearance. Most common sites are cheek, buccal mucosa, angle of the mouth, alveolar mucosa, tongue, lip, palate, and floor of the mouth. 4 to 6% of cases return into malignancy. The most common etiological factors are tobacco smoking. Other etiological factors include ill-fitting dentures, jagged teeth, local irritants, spicy and very hot foods, beverages, and alcohol. A special variety of leukoplakia called hairy leukoplakia is seen in HIV patients, which occur as a hairy or a corrugated surface, but is not related to the development of oral cancer. Grossly, leukoplakias are a white or whitish yellow lesions or red velvety lesions of more than 5 mm in diameter. They are usually circumscribed, slightly elevated, with a smooth, wrinkled, speckled or nodular surface. Histologically, leukoplakia is of two types, hyperkeratotic type and dysplastic type. Hyperkeratotic type shows an orderly and regular hyperplasia of the squamous epithelium with hyperkeratosis over the surface. In the dysplastic type, it shows irregular stratification of the epithelium with focal areas of abnormal and increased mitotic figures, hyperchromatism, pleomorphism, loss of polarity, and individual cell keratinization with lymphoplasmacytic infiltration beneath the cell. Usually, mild dysplasia may revert back into the normal if the offending etiological factor is removed. Severe dysplasia may progress into carcinomas. If dysplasia is extensive, involving the entire thickness of the epithelium, it is called as carcinoma in situ, which may progress into invasive carcinoma. Here is a form of dysplastic epithelium. This is an image in the showing erythroplakia, which is a white patch seen in the oral mucosa. This is slightly elevated compared to the surrounding oral mucosa. This is a microscopic picture leukoplakia showing severe dysplasia of the cells. Pleomorphic cells are of different sizes, some are showing mitotic activity, and the size of the epithelium is increased, which we call as hyperkeratosis. This is a hyperkeratotic type of leukoplakia, and this is the dysplastic type of leukoplakia. There is a regular enlargement of the epithelium, which is seen in hyperkeratosis, and there is an irregular and disorderly arrangement of the epithelial cells, the bizarre arrangement of the nucleus. Next is benign tumor arising from the squamous epithelioma, which we call as squamous papilloma. This is the most common oral neoplasms. It affects the people of all ages. Males are most commonly affected. Most common etiological factor is human papilloma virus of strains 2, 4, 6, 11, 13, and 32. Mechanical irritation is a risk factor for squamous cell papilloma. The most common sites are palate, tongue, gingiva, and lips. Grossly, these lesions are painless, present as an exophytic growth. They may be white to pink mass with a warty or papillary surface. Microscopically, they are broad papillary projections composed of hypoplastic stratified squamous epithelium surrounded by a scant fibrovascular core. Hyperkeratosis, parakeratosis, and inflammatory cells are also seen within the microscope. This is a gross picture showing exophytic growth above the mucosa. This is a microscopy showing papillae surrounded by a thin fibrovascular septum with an enlargement of the squamous epithelium. The malignant tumor arising from the squamous epithelium is called squamous cell carcinoma. This is the most common malignant tumor occurring in the sun-exposed sites in older people. Men are most commonly affected. Some of the risk factors include fair-skinned people, sun-exposed areas, xeroderma pigmentosum, chemical exposure to coal tars and oils, ionizing radiation, chronic ulcers, old burns, scars, draining sinuses of osteomyelitis may be a predisposing conditions for occurrence of squamous cell. The common locations are they can occur anywhere on the skin, most commonly on face, pinna of the ear, back of the hands, epicutaneous junctions, anal canal, and glans penis. They occur as an ulcerated growth with elevated and indurated margins. They occur as a fungated or polypoided verrucous lesions without ulceration. This is a gross picture showing ulcerated lesion, polypoidal growth with an ulcerated lesion and indurated margins. Grossly, they occur as nodular lesions with central ulceration and rolled out margins. Microscopically, these cells are arranged in nice sheets showing pleomorphism, high mitotic grade. Cells are large with moderate amount of pink keratinized cytoplasm. Squamous cell carcinoma is graded into well-differentiated, moderately, and poorly differentiated depending upon the differentiation into the parent epithelium. In well-differentiated squamous cell carcinoma, the tumor cells are arranged in nest sheets and the islands with a pleomorphism. Keratin pearls are seen, well-formed keratin pearls are seen within the epithelium, within the tumor, and the cells are showing increased nucleus to cytoplasmic ratio. In moderately differentiated squamous cell carcinomas, few keratin pearls are seen with individual cell keratinization. In poorly differentiated squamous cell carcinomas, there is a little keratinization of the cells with absence of intercellular bridging. There is a marked pleomorphism of the tumor cell. This is a picture showing a fungating growth over the pinna. And this is a schematic diagram of the squamous cell epithelium. There is a microscopic picture of squamous cell carcinoma. This is the epithelium and this is the tumor tissue. Tumor is invading into the derm. This is a gross picture with indurated margins and microscopy showing this is the normal squamous epithelium. This is the squamous epithelium turning into a invasive squamous cell carcinoma, which is extending into the dermis. These are the pleomorphic cells with mitotic activity. These are the keratin pearls seen within the tumor. The next common tumor is the basal cell carcinoma. This is also called as rodent ulcer. This occurs as a locally invasive, slow-growing tumor, most commonly occurring in the middle-aged people. These tumors are slow-growing and rarely metastasize into other structures. They occur most commonly on the skin and face, most commonly over the imaginary line drawing above a line from the lobe of the ear to the corner of the mouth. Grossly, the tumor cells resemble those in the normal basal layer of the epidermis. There are two patterns are seen, and multifocal growths originating from the epidermis and extending over the several square centimeters or more of the skin surface, or nodular lesions growing downward deeply into the dermis with basophilic cells embedded in the. These cells are arranged in nests which grow downward and are extending into the dermis. These cells show peripheral palisading. The stroma retracts away from the carcinoma, creating peritumoral clefts. This is the most significant feature of basal cell carcinoma. This is a schematic diagram showing tumor over the face along the line joining ear lobule to the angle of the mouth. This is a schematic diagram of epithelium showing basal cell carcinoma occurring into the dermis. This is a tumor with a peritumoral cleft, and this arrangement of nucleus is called as peripheral palisading of the nucleus. There is a microscopic picture showing nodular tumor. This is the normal epithelium, and this is the tumor tissue arranged in nodular pattern with a peripheral palisading. This is a gross of the tumor with a nodular-like lesion, and this is a microscopy showing nodules, and this is a high-power view of the nodule showing the tumor tissue. This is the peritumoral clefting. Next, most common tumor is the fibroma. This is a benign tumor arising from the fibroblast. This is composed of spindle cells which have a bland and wavy nucleus with a whorl arrangement. Ovarian fibromas are the most common. Fibrosarcoma is the malignant tumor of the fibroblast with a herringbone architecture and a variable collagen. These are rare tumors. Most of the patients are above 40 to 55 years. Fibrosarcomas arise from superficial and deep connective tissues like fascia, tendon, periosteum, and scars. Usually deep soft tissue of lower extremities, trunk, retroperitoneum, or mediastinum are affected. They grow either rapidly or 50% of the tumors recur and 25% metastasize to bone and lung. More metastases occur if the fibrosarcoma is more cellular. Grossly, they appear as a well-circumscribed, non-encapsulated lesions with a soft fish flesh-like mass on cut surface showing a white tan homogeneous area with hemorrhagic and necrotic areas. This is a gross picture of fibrosarcoma appearing as a soft fish flesh mass. Microscopy shows highly cellular fibroblastic proliferation. Typical arrangement of the cells is called as a herringbone pattern. These cells in herringbone pattern, one row of cells are arranged in parallel lines to the adjacent columns of the cells. This type of pattern is called as herringbone pattern, which is typical of fibrosarcoma. These cells have a scant cytoplasm with a tapering, elongated dark nuclei with increased granular chromatin and variable nucleoli. Mitotic activity is variable in this. This is microscopy showing the herringbone pattern. These cells are this column of cells are arranged parallel to this column of the cells, giving the herringbone pattern. The next common tumor is lipoma. This is a benign tumor arising from the adipose tissue. It is the most common soft tissue tumor of adulthood. They arise from the yellow fat and they occur anywhere in the body. Hibernoma is a benign tumor arising from the brown fat. Causes for lipoma may be variable and they may be because of hereditary causes like familial multiple lipomatosis occur due to Gardner syndrome, Dercum syndrome, and minor injury that trigger lipoma may be encapsulated, diffuse, or multiple. Histological types of lipoma are conventional lipoma, fibrolipoma, angiolipoma, spindle cell lipoma, myelolipoma. This is a gross image of lipoma, which is soft, most commonly seen over the nape of the neck. They are soft, which are slippery to touch. Grossly, they are well encapsulated. They may be small or large masses. They are soft masses. They are gray-yellow with a lobulated surface. Cut surface shows gray-white or gray. Microscopically, mature adipocytes are seen arranged in lobules, which are separated by a thin fibrovascular septum. The microscopy of lipoma showing mature adipocytes with an peripherally placed nucleus. And these are the blood vessels, and this is a capsule. Adenoma and adenocarcinoma. Adenoma is a benign epithelial neoplasm which is derived from the glands, and adenocarcinoma is its malignant. This is most commonly seen in the stomach. They constitute 5 to 10% of all the polypoidal lesions. By definition, adenomas contain a proliferative dysplastic epithelium which has a malignant potential. They may be sessile or pedunculated, and the most common location is the antrum. This is a fungated lesion over the gastric stomach mucosa. There is a microscopy of adenoma showing papillomatous growth, stratification of the epithelium. Depending upon the shape, they are classified as tubular adenoma, villus adenoma, and a mixed adenoma. This is the normal microscopy of normal colonic mucosa, and this is adenomatous polyp, in which their glands are enlarged, showing stratification. Number of layers of the cells are increased. This is called as adenoma. If there is atypia among these cells, carcinoma. This is a microscopic picture of adenocarcinoma showing glandular arrangement of the cells. All the atypical features like hyperchromasia, increased NC ratio, nucleus to cytoplasmic ratio, prominent nucleoli, all are seen within these tumor cells, and the pattern of arrangement is in the glandular form. These tumor cells are arranged in a glandular pattern. This is the adenocarcinoma. This is all about some common specific tumors. Thank you.